Hello, everyone. Welcome. We're going to start. I'm Floris, and I'll be your host today. And welcome to the very first BRAMS CRBLM lecture of 2022. I know we would have loved to be in person today, but unfortunately we cannot. And I'm really excited to see that so many of you were willing to do the online version with Zoom. So it's a great pleasure to welcome today the first speaker of the year, and that's none less than Diane Lazard. Many of you probably know her already, so I might not even need to do an introduction, but just for the decorum, Dr. Lazard is an ENT surgeon and a neuroscientist at the Hearing Institute Pasteur in Paris. And she has a remarkable trajectory in science. She got her PhD from the École Normale Supérieure in Paris. I don't know, maybe for some of the students who don't know the École Normale Supérieure, that's like a very prestigious institute in France. It's presumably one of the best institutes to do your PhD at, after BRAMS, of course, that is. And Diane Lazard went on to do her postdoc at the Bionics Institute in Melbourne and at the Institute of Neurosciences in Montpellier. She's currently collaborating with Alexandre Lehmann on a project on actually the McGill cochlear implant project. And so maybe we're going to hear some about that today as well. Really looking forward to your talk. Diane, the floor is yours.
Thank you. Thank you for the nice introduction. The good thing about Zoom is that we can see everybody's face and smiles. So we're going to be positive. Thank you for your invitation. I'm very honored to present today. Hello, Franco. Okay, so I'm going to start. I'm going to close the windows. All right. So just to say, yes, all right. So I'm co-leading a team at Institut de l'Audition, as said Floris, at Institut Pasteur. It's a very new building, a very nice place. I co-lead with Luc Arnal a group called Auditory Cognition and Communication Lab. And here it's a picture of Luc and Keith Darling, that is our postdoc. So I do my surgical practice at Institut Arthur Verne and my research at Institut de l'Audition. So as an ENT surgeon, I'm interested in deafness, of course. So we know that in developing brains, deafness can impair language development, induce behavior disorder and academic difficulties, and can be associated with other disorders. In adults, deafness can impair professional performance, lead to social isolation, depression, and accelerates cognitive decline and dementia. So I mentioned rapidly the work from Franklin you must be aware of, because I will go back to that in a second part of my talk about aging. So deafness is a unique model of sensory deprivation, handicap adaptation through sign language and lip reading, and we have access to rehabilitation and reafferentation with auditory prosthesis and cochlear implants. So for neuroscientists, it's a very nice model. So I got really interested in the variability in speech rehabilitation, and especially in cochlear implanted subjects. You can see here an example of this variability. So it's word recognition in postlingual deaf CI users, so pre-implantation and over time. And you can see that after 1 year of implantation, you have star patients who understand 100% of the words and some who don't understand anything. So this was my topic of interest. Why do some subjects do not manage to understand speech with the cochlear implant? So we know that we have predictors of cochlear implant outcome, peripheral and anatomical. So for example, you have the placement of the electrode within the scala tympani, the depth of insertion, and also the residual neural population. So we need a good neural interface between the electrode and the nerves. And on general point of view, 25 years ago, Peter Blamey in Australia demonstrated that 5 main factors were important and had a negative effect. The duration of severe to profound hearing loss, age at implantation, age at onset of profound hearing loss, etiology, and the CI experience had a positive effect. So as it was mentioned, I did a postdoc in Australia, and I had the chance to work with Peter Blamey. So he asked me to update this study, and we managed to gather more than 2,000 data from cochlear implantees. So data from more than 2,000 cochlear implantees. And we designed this model of auditory performance over time, including in our statistical model, 15 clinical factors. So 10 more than the previous ones. So here you have the expected auditory performance if you were to implant the subject. Here you have time. So we have modeled the duration of moderate hearing loss, the duration of severe to profound hearing loss. And from the date of implantation, you can see what we call the learning curve, and it is related to plasticity. So it was the first time that we were able to show that the duration of moderate hearing loss had a negative impact on the expected performance. Here you can see that the slope is steeper during the duration of severe to profound hearing loss, and the 2 lines here show the difference if the patients maintain their hearing aids during this period or if they had no hearing aid. And you can see that we can say that having 2 hearing aids during this period of severe to profound hearing loss seems to protect against modification in the brain, so plasticity, maladaptive plasticity probably. However, these 15 clinical factors only explain 22% of the variance of the outcome. So I wonder, where does the remaining of the variance come from? And I got interested in the cognitive factors during my PhD with Annelise Giraud. So my neurofunctional hypothesis was, is phonological processing altered in postlingual deaf and cochlear implant subjects? So the idea came from these 2 studies. You have subjects listening to words or sentences, so it's phonological auditory tasks. So it's PET studies because the subjects are implanted, so MRI is forbidden. In the first study, you have controls, listening, normal hearing controls, listening to words, and you can see the activation within, of course, the left temporal cortex. If you compare to CI users who have good performance with their implant, you can see that the activation is more pronounced, and you have other areas that are recruited. Here you have a comparison of 2 groups of cochlear implant users. The group here has a high comprehension with the cochlear implant, and this one has a low comprehension. And you can see also the difference with the non-proficient CI user showing no or very low activation in temporal cortices. So the question was, is phonological processing more demanding in CI users? And can we observe an impaired matching between the vocoded signal from the implant and internal phonological representations? So to investigate auditory memory and phonological representation in cochlear implant candidates, I base my work on the speech processing and reading mood models. You must be aware of this model, so I'm going to go quickly on these. So here you have the model from Eacock and Popple for speech processing. So it's left dominant on the left hemisphere. You have a first entry within the auditory cortex, a very basic phonological analysis in the left superior temporal sulcus, and you can use either the dorsal route, that is an articulatory and analytic dorsal stream, or you can use in pink, the ventral stream, that is a lexicosemantic route. And if you compare to the reading model, you can see that, of course, the first entry is visual, so you use the occipital cortex. The basic analysis is within the word form area. And then you can use either the dorsal route if you need to have access to pronunciation, or the ventral route if you have read already the word you're reading and you have direct and rapid access to its meaning. So what I like to use as an example is acetyl salicylic acid, aspirin. So the first time you're going to read this very long and strange word, you need to get access to pronunciation. So you're going to use the dorsal route. But once you know that it is aspirin, you have a global recognition and you will use the ventral route. So you will have a faster access to the meaning. So if we merge these two models, of course, we have different primary and early associative areas, the auditory cortex and the visual cortex, but after you can see that the roots are common. So we have common high order streams. What's happening in case of deafness? So we have the loss of the auditory modality. Subjects need to rely on the visual modality so they can grab help from reading or lip reading. So in order to investigate auditory memory and phonological representation, so the dorsal route, I use the visual modality and I use reading and lip reading tasks that I'm going to show you. So here is my experimental paradigm. I tested the postlingual deaf adults, candidate for cochlear implantation, and their paired normal hearing controls. They were doing different tasks in an fMRI scanner. The deaf subjects were implanted, and 6 months after implantation, we were recording their performance with the cochlear implant by studying word recognition. So the first one was a written rhymes. That is an easy phonological task. So the subjects could see 2 words on a screen, and they had to say whether the words were rhyming or not. So you can see poisson, garçon. It was quite easy. The second task was a silent lip reading task. So they were seeing lips moving, and this digs into the viseme phoneme matching, so the audiovisual interaction. And the third task was a sound imagery task. So the subjects were viewing these pictures of animals or noisy objects, and they had to say whether imagine the sound produced by the image. So this taps into the prosody and paralinguistic processing. So if we look at the fMRI results, so I'm going to show you the results in the controls and in the deaf. And because I'm interested in the scores and the factors that can predict cochlear implant outcome, I will also show you the correlation with the cochlear scores obtained 6 months after implantation. So in purple, you will see the positive correlation with the cochlear implant scores. That is the areas that are activated by the subjects who are deaf, but who will be proficient CI users. In green, it is the negative correlation with the CI outcomes. So you will see the areas that are activated by the subjects who will become non-proficient CI users. So for the first task, the written phonological task, here in controls, you can see that we have exactly what we wanted. So an involvement of the occipital cortex, the word form area, and the dorsal root that it is left dominant. If we look at the positive correlation in purple, so the areas activated by the subjects who will become proficient CI users, you can see that they use the dorsal root. Now, if we look at the negative correlation in green, you can see that the subjects were using the ventral root. So they were able to perform the task because it was an easy task. So the subjects recruited the ventral root and also recruited this right area in the temporal cortex. So from this first study, we were able to say that the reading strategy developed during deafness was a predictor of cochlear implant outcome. We then got really interested in this activation. And here I plotted the activation in the controls and in the deaf. And of course, in the deaf, you can see at baseline that there is that they are at baseline. There is no activation in the control. That's exactly the same image at this. So of course, it's a right area that is not used usually to process phonology. But you can see that the deaf need to recruit this area to process phonology. So this right involvement is a plasticity that seems to palliate the difficulties that the deaf subjects encounter when they need to process phonology. So this right involvement has been previously described after aphasia and stroke. The patient recruit the right area to help recover from the aphasia. If we look at the lip reading results, you can see here the results in the controls. So a wider network. If we compare it to the deaf subjects, it's more or less the same, but it's more extensive in the deaf subjects. So we can say that the deaf subjects may have a greater phonological access from the VSEM they receive from the lips. I put here the result, I merged the results from the phonological task to show you that I got interested in these three areas that are multimodal. And I extracted the neural activity, the activity level in these three areas. I just showed one correlation, but I had the same tendency. And I plotted the activity, the amount of activation against lip reading ability. And you see that I obtained a positive correlation, showing that the good lip readers activate more these areas. So the better lip reader have managed to really transform these areas to have greater access to the language from lips, sorry. So we can say that in these multimodal areas, we have a potentiation of the visual modality through audiovisual integration in the deaf. Now we have the sound imagery results. So in the controls, we have a bilateral involvement, and especially this right area that is known to be used to process paralinguistic and prosody. And we can see that in the deaf subjects, we have a network very different, and especially they don't recruit anymore this right temporal cortex. So this area is not used by the deaf to process paralinguistic cues. And if you remember, the same area was recruited during the phonological task in green and during the lip reading task also in blue. So I got more interested in this reorganization of the right temporal cortex. So during phonological processing and during lip reading, I extracted again the neural activation within this area, and I plotted against several clinical factors. So the first correlation is with deafness duration. And you can see that we obtain a positive correlation. So it means that the longer the duration of deafness, the more this area is activated. So we can say that we have really a plasticity that is driven by deafness in this right area. The second correlation was with lip reading ability. So during the lip reading task, and you can see the result of this correlation, non-significant. So it means that the deaf subjects activate this area during a lip reading task, but it is not useful to understand the language from the lips. So it is what we call a non-efficient repurposing. Now, the other clinical factors were the scores during the phonological task and the scores obtained after implantation, so the word recognition scores with the implant. Again, to simplify, I just show you one correlation, but the tendency was the same for the two correlations. And we obtain a negative correlation. So it means that the patients who were not very good in performing the phonological task and who were not good CI users, who were not able to understand speech with the cochlear implant, were activating the more this area. So this overactivation, in fact, is detrimental. So we call that a detrimental reorganization or maladaptive plasticity. So the deaf ask the right hemisphere to do phonology. The right hemisphere is not specialized, and especially this area is not specialized in phonology. So it doesn't manage to process phonology, and it even turns out to be detrimental. So I use the example of stroke, and it's the same. When after aphasia, when after stroke you have aphasia, and there is a right recruitment of the hemisphere, of the right hemisphere, the patient do not recover well from aphasia. So I told you that the subjects were able to perform the rhyme using the ventral stream based on a very easy rhyming task. So I wondered what would happen if the dorsal root was mandatory. So to manage to have the dorsal root mandatory, I designed a more difficult rhyming task based on pseudo-homophones. Pseudo-homophones are real words, but that are misspelled. So you can see here Africaine et Mexicaine, real French words with a misspelling. So you really need to have access to the pronunciation to be able to perform the rhyme. So the dorsal root is mandatory. And I also looked at lip reading ability before implantation. So you can see here the results of the fMRI study with for the normal hearing controls. We have, again, the occipital cortex, the word form area, and the dorsal root that is dominant on the left hemisphere. And for the deaf subjects, same pattern, but it was more demanding for them. So for this task, I particularly looked at the behavioral results because I had a strange profile of patients. I'm going to tell you that. So if we look at the performance, we can see that here in gray, we have the deaf subjects, and in white, the controls. So we had tendency for lower performance in the deaf subjects, but it was not significant. But what was unexpected, that is that the deaf subjects showed very fast reaction times, and it was significant. So the deaf subjects were able to reply faster. So you can say we have subjects that tend to reply less well than the controls, and they reply faster. Maybe they reply randomly, and not at all. In fact, I had a subgroup of deaf subjects who performed very well during the rhyming task. So they had performance more than 75% of accuracy for the rhyming task. And I looked at their reaction times and compared their reaction times with all the controls, and the controls who also had very good performance during the rhyming task. And you can see that we have these deaf subjects who are very good rhymers, and at the same time who reply fast, very fast. So they are good rhymers, good at the phonological task, and fast responders. So reaction times seem to be an important clinical factor. So I plotted against the speech scores with the cochlear implant. And you can see that I obtained this nice positive correlation, meaning that those subjects who reply very quickly here turned out to be poor CI users. On the other hand, the subjects who replied with normal range reaction times, because these were at the same delay than the controls, became proficient CI users. I also looked at the correlation between reaction times and lip reading, the ability to lip read, and I obtained also this nice positive correlation, meaning that the same subjects who have normal range of reaction times, who became proficient CI users, were good lip readers. And those who were efficient and rapid during the rhyming task were not good lip readers and became non-proficient CI users. So we have these two clinical profiles: fast, efficient readers who are poor lip readers and who will become poor cochlear implant users, versus slower readers who are good lip readers and who will become good cochlear implant users. So I was able to explain these two profiles thanks to the MRI results. So I'm going to show you the neurofunctional traits linked to good cochlear implant performance. You can see here the positive correlation with reaction time. So the area that is recruited by the subjects who are slower responders, and you can see that it is correlating with the left STG, superior temporal gyrus, that is an area known to be specialized in phonology. The same area overlaps with the positive correlation with lip reading, so with the good lip readers, and still the same correlates with good cochlear implant scores. So it means that the subjects who were good lip readers maintain left physiological involvement, so a normal use of the dorsal pathway, and became efficient CI users. So if we look at the neurofunctional traits linked to poor cochlear implant performance, you have here in green the negative correlation with short reaction time, so the subjects who reply very fast to the rhyming task. The same areas overlap with the negative correlation with lip reading, so poor lip readers, and also with the negative correlation with the CI scores. So what is really interesting is that we have the involvement of the occipital cortex and a right involvement again. So the deaf subjects who were poor lip readers needed once again to recruit the right hemisphere to palliate their difficulties in phonological processing. However, they became non-efficient CI users. So we better understood also the profiles thanks to connectivity. We took as seed regions the occipital cortex and the right temporal cortex, and we were able to show that these areas were interacting together and interacting with Broca's area. So we explained the very fast replies during the rhyming task thanks to this new network. So engaging the occipital cortex, the right temporal cortex, and going directly to Broca's area, skipping the usual left phonological areas. So here we have again a plasticity based on the right occipital-temporal coupling that is efficient during deafness because it allows the subjects to stay in interaction with their peers.
Quelqu'un qui skie, comment ça s'appelle?
Somebody let her microphone. So, sorry, I lost. So, yes, so they cannot lip read, so they are involved in a reading strategy. So they're able to, people who want to interact with them, write to them. So they became very efficient readers. So this strategy is efficient during the period of deafness, but if they choose to be implanted, it is maladaptive in case of auditory rehabilitation. So the occipital cortex involvement is seems to be a very important predictor of cochlear implant variability. So Pascal Baron in Toulouse showed that when the occipital cortex is engaged in a left network, It will predict good CI outcome because the subject is engaged in an audiovisual strategy. And we showed that when the occipital cortex is engaged in the right network, then it will predict poor cochlear implant outcome because the subject is engaged in a reading strategy. So the occipital cortex and its involvement in audiovisual integration play a central role during deafness and after during its rehabilitation. So this is the conclusion of the first part. So we can say that auditory memory and its networks modify when not kept active by auditory inputs or lip reading. Oral communication difficulties induce specific plasticity. This plasticity may be maladaptive, relying on non-dedicated areas in the right hemisphere. So if we want to apply this to the clinics, we can say that we have to maintain analytic networks active by using hearing aid use early in the period of deafness, and promote cognitive training to maintain a functional organization. So these conclusions were driven from patients younger than 65 years old, but now I got interested in elderly patients, and I wondered whether plasticity existed in the aging brain. So as I told you in my introduction, Franklin showed that there is a statistical association between hearing loss and accelerated cognitive decline, and Elena Mieva was able to show that wearing hearing aids prevented from this acceleration of cognitive decline. So if we want to schematize, we can say that if we add aging and deafness, we know that this is going to improve social isolation, depression, and cognitive burden, and this would lead to accelerated cognitive decline. So my question is, can we potentiate plasticity to revert this process? So with Peter Blamey, thanks to the big data set, we were able to show that age at implantation had a negative effect. You have here the age at implantation, and here the scores with the cochlear implant. It is expressed in residual percentile rank. It's a bit long to explain, but you have to understand that 0 is 50% of word recognition. So you can see that we have a slight decrease in performance with age, but it turns out to be significant from the age of 70 years. So I extracted two populations and compared them to understand what was happening in these aging brains. So a reference group aged less than 50 years and an elderly group aged more than 70 years with more or less the same number of subjects. I first compared their preoperative scores, so without the cochlear implant. And you can see that there was no significant statistical difference. So the two groups started at the same baseline before implantation. If we look at their score after implantation, I have 2 points at 6 months after implantation and at 2 years after implantation. And you can see that from 6 months, we have already a significant difference between the two groups, and it's greater after 2 years. So, of course, elderly patients benefited from the cochlear implant, but not as much as the reference group. So I got interested in what I call the delta speech, so the difference between the scores at 2 years and 6 months. So it is the learning curve, and I told you that it represents indirectly plasticity. So I plotted this score difference, the delta speech between 2 years and 6 months in the two groups. Here you can see the results from the reference group. So 0 means that the scores stayed stable between 6 months and 2 years. A positive score means that the patient improved their scores, and a negative result signs a regression in the scores. So if we look at the proportion, a great amount of subjects improve their performance over 2 years. 16% stayed stable. I explained this proportion with non-reversible plasticity, subjects who are not able to reverse their maladaptive plasticity after implantation. And 7% of regression is marginal, so I won't discuss this. If we look at the results in the elderly, the proportion is interesting. So also more than half of them managed to improve the scores, but 22% remain stable, and 16%, that is quite important, reversed their scores. So from these, I described 3 putative trajectories, plastic trajectories. The first one, I called it awakening. The second one, I called it stabilization. And the third one, decline. So I'm going to detail these hypothetic plastic trajectories. Awakening would correspond to healthy aging in these subjects aged more than 70 years. And these subjects are able to develop a positive plasticity following auditory rewiring. So they are able to reactivate their auditory networks. And this will fight against social isolation, depression, and cognitive decline. Stabilization include, as well as the reference group, patients who are not able to reverse their maladaptive plasticity, but also the larger proportion may be explained by subjects who may have associated cognitive decline, for which auditory rehabilitation slows down the evolution to cognitive impairment. So this hypothesis comes from animal models of Alzheimer's disease. So we know that it corresponds to an accumulation of beta amyloid proteins. So they were mice with Alzheimer's disease. They were treated with sound therapy. This sound therapy was click trains at the frequency of the click trains with the frequency of 40 Hertz. And after several days of sound therapy, it was shown that the mice had an improvement in their memory and in their brains. There were less beta amyloid, significant less beta amyloid accumulation. So we can make a parallel maybe with Alzheimer's disease patients. And the third trajectory would be the decline. So this patient may present a pathological process whose evolution is not influenced by auditory therapy. And for example, we have as negative predictors high blood pressure, microischemia, and especially white matter lesions, whereas independent negative factors of course, all this is hypothetical, so we need to be confirmed by hypothesis. So to conclude, auditory intervention in the elderly may be a strategy. Plasticity exists in this population, and we can potentiate it using hearing rehabilitation and auditory training and stimulation. So auditory training would be musical therapy, and stimulation would be the same as the stimulation for click trains at 40 Hertz. About this, start with Carnal. I thank you for your attention, and here is my team with colleagues and students.
Thank you very much, Diane, for that. I don't know if you can see in the participant list, there's like some applause. It's virtual these days, right? So, but it's real. And so after this fantastic talk, I'd love to invite some questions. So anybody in the audience, please feel free to like raise your hands. You probably know where to find that. It's like under the button reactions in your Zoom, and then you click on raise hands. Or if you're shy, that's fine too. You can write it in the chat and I'll read it to Diane. We have one question from Robert.
Oh, can you hear me?
Yes, I think we can hear you, Robert. The quality is not great though.
Can you hear me better now?
Yes, this is better.
Great.
Hi, Robert.
Thank you, Diane. Very interesting. I learned a lot about the approach that you're taking, which is nice because it has such a clear translational element. I was wondering, though, you characterized the engagement of some of the auditory regions in, I think it was lip reading and some of the visual tasks. You characterized it as maladaptive. And of course, it is maladaptive, as you've shown, with respect to language. But it might be adaptive in other ways. And I'm thinking of some of the studies that suggest that there is an enhancement of visual processing in the deaf, particularly in the periphery of the visual field. And I wonder if what you think of that hypothesis, and possibly it's related to the idea that, especially for sign language, you may need better ability to capture some of the fine movements that occur in the periphery as the person is signing. So I wonder what you think of that concept.
Yes, you told me it's if the subjects choose to be implanted, and that's what I'm interested in, the result of cochlear implant. The strategy was efficient during deafness. So of course, it was a positive help them to adapt during deafness while because they were not good lip readers. My subjects were postlingual deaf subjects, so they were not using sign language. They were oralisants en français. I don't know how you say in English. They were used to talk and not use sign language. So signers are prelingually deaf. So it's the plasticity has occurred during their infancy. So it's very different reorganization of the brain because we know that the cross modality, the visual cross modality is greater when the deafness is congenital. So I think it's not exactly the same population, so not exactly the same question. If I understood.
Yeah, that makes sense. Thank you. I guess it might be interesting. I'm thinking just to test for non-linguistic visual abilities, because maybe you would see a trade-off between, enhancement of visual processing and decrement of lip reading, or vice versa.
Yes, of course. Yes. It's interesting to test all the aspects of the communication and of hearing. So, of course, there's language, but there's also all the ecological environment. So, what are called prosody and paralinguistic sounds that are also really important to keep the lateralization of each hemisphere physiological. So if we talk about training during deafness, before implantation, we have to be interested in language, but not only. I think that all the aspects of auditory memory should be trained, and also the paralinguistic memory. And when deaf subjects have an implant or hearing aids, they say, "Oh, but I hear the clock that I forgot that the numbers, I couldn't hear the numbers before." Or when I walk on the snow, for example, I forgot this sound. It's very nice sound. This little thing that you know when you're here, but you forget with time, with duration of deafness. I think these sounds are very important to leave the physiological organization of each hemisphere to maintain this.
Thank you.
Thank you, Robert, for that question. And the next question is, we stay in the same household. We have Virginia.
Hi there, it's a pleasure to meet you.
Hello.
So I'm curious about some of the aging data, because you're framing these differences between the older adults, like the 70 years and older, and the 50 years and less, as being related to some kind of plasticity that's occurred, and that you're thinking of this in a way as maladaptive plasticity that prevents people from using the cochlear implant efficiently, right?
You still see my screen?
Yep.
So when they manage to increase, it means that maybe they had maladaptive plasticity, but they are able to reverse this very quickly during the 2 years. So they manage to improve in the two groups, reference and elderly. For those who stay stable in the reference group, it's easier to understand in the reference group. I would say that if we look at cognitive factors, we may explain this non-progression by the incapacity to reverse maladaptive plasticity.
Right, but that's my question, is that you're thinking of this as being evidence of maladaptive plasticity, but you could also think of it as simply that the people who are older have 20 more years of experience using, right? So they're older. I don't know how this is related to the length of time since deafness, since they became deaf. So in other words, you have people who have more time doing this language task the way they're accustomed to doing it, right? So is that maladaptive plasticity, or is that simply that they're efficient in one way of doing the task and not so efficient in the other, and that there may be many other cognitive factors that have nothing to do with plasticity,
of course,
right?
No, it's just
so that's why I was curious about framing this in terms of plasticity, because although we certainly know, and I mean you have showed it elegantly, that there is plasticity, often we're seeking to produce plasticity and it's hard to do, right? So is it also important to think about the cognitive status and these other cognitive variables that might come into play in people's ability to use the cochlear implant efficiently? And would those be the targets that you want to look at to improve outcome? Mm-hmm. Whereas fighting plasticity may be very hard, or even driving plasticity may be hard.
Yeah, I agree. I perfectly agree. Just to comment, so I compared the duration of deafness between the two groups, and it was not significant. So we cannot say because they are older, they have a longer duration of deafness. They were equal in duration of deafness. So we cannot.
But they have a longer duration of language experience.
Yes,
right.
Of course.
Right. I mean, just thinking of it in terms of like sort of fixedness of a cognitive style or pattern.
Mm-hmm.
So that, anyway, I was just curious about that idea of like, because I think it does seem very interesting to think about the other cognitive factors. So have you thought about those? And what are the things that you think might be important for rehabilitation that maybe we're not taking into account?
You're muted.
Oh, sorry about that. I just wondered what the other cognitive factors are you think are important.
These data are not from my linguistic, my phonological task, and they're just about word recognition with a cochlear implant. Of course, you have aging, healthy aging, and pathological aging. So these are just retrospective data without cognitive testing. So it's just really putative. That's why I need to be very cautious with these results. And of course, we need to test the patient in terms of attention, memory, working memory, all these things to, of course, I'm not going too far in the interpretation of my data. I agree with you. It's a very good remark.
Thank you, Virginia. Thank you, Diane. We have time for more questions. And in particular, also, I'd like to invite the students also. This is also an opportunity for you. It's not just for the big shots to ask their questions. If you're curious about anything, this is your chance. I see, Berak, you have a little applause signal. Was that actually, did you intend to ask a question or?
Yeah, sorry, yeah. I was meaning to raise my hand. Thank you, Diane.
Go for it, Berak.
Thank you, Flores. Thank you, Diane, for this wonderful presentation. I think my question is in parallel to Virginia's question. So I was wondering that were you able to perform any cognitive or neuropsychological tests in the elderly group? So because that would be very interesting to see maybe in the future.
Yes, in the future. No. They're really the data I had. So it's a big cohort. If we look at the numbers, it's the biggest. I was able to have a really great number of subjects. So yeah. My aim was also to show that the elderly perform less because if you look at the cochlear implant literature, it's not that clear that the performance are not that great in the elderly. Of course, they gain from the implant, but not as well as the rest of the population. And the literature is not that. And I thought, I have the direct access to plasticity. But of course, I didn't have at that time cognitive measurements. So it's the big lack of these results. It's just behavioral and it's just observations and then my thoughts.
Thank you.
I have nothing really to prove.
Maybe in the future. Thank you. That was all great. Thank you for your answer.
Thank you.
And next we have Simona.
Hi, Diane. Nice to meet you too. Thank you so much for your talk. I'd like to ask you a question by picking back on what Virginia said before about the individual differences that you showed and the different kinds of profiles that you basically showed. Maybe you could move on to the next slide that you showed. Can you still hear me?
This one?
No,
yes.
the following one. Yeah, this one.
You were talking about this slide?
Yes, exactly. Yeah. So I was wondering, so it seems to me that when we look at the group of the elderly, well, there are, of course, huge individual differences, but these individual differences seem to reduce with age, which is probably also partly due to the fact that you have a sample which is not equal across the age span that you're studying. But I was wondering, so when you talk about stabilization, is there any criterion of clinical meaningful difference, because you're using a delta here? So if somebody is in the vicinity of 0 or plus, I don't know, or minus a given value on the delta, so is this clinically meaningful? And what is the criterion that you use? And is this criterion always the same also across the age span?
Sorry, I didn't get the question. So these are individual plot. So
right.
After 2 years, you expect that the patient increase his score, because that's the learning curve. So I didn't get the question. I'm sorry.
No. What I mean, well, you're talking about stabilization. So, but what's at which point you're talking about an increase or a decrease in the delta? Because there must be a clinically meaningful difference there.
Yeah, sure.
As a criterion. So is this criterion changing as a function of age? Or are you using exactly the same criterion? I assume that the criterion may be different for a 70-year-old and then from a 80-year-old or a 90-year-old. What is the frame of reference for you here?
No, I consider that between plus 5% and minus 5%, it was a stabilization. But I use the same scale for the reference group and the elder group to compare what was comparable. So because if you look at, for example, some that are 85 years old and plus, they were able to increase their score of 50%.
Right. But my point was that, I wonder if this difference may be clinically meaningful in a different way for very old adults as compared to, people who are below 50, right? So a change of plus or minus 5% may be meaningful for a 50-year-old, but may be more part of the normal variability that you encounter in an 85 or a 90-year-old. I was just curious about that. So maybe the concept that what is stable for a younger adult is not the same as for an older adult, right? So you may want to in a way modulate the three categories weight them.
Yeah. Okay, I will think about it. Thank you. I will try to do that. I'm gonna put it down.
Great. And then we have Karina. I hope I pronounce your name correctly.
Yeah, thanks for a great talk. I'm assuming that all of the elderly adults were post-lingually deaf, but I was wondering if the cognitive decline that you mentioned that was associated with deafness existed in pre-lingually deaf adults, like people who have been deaf for their entire life. Like, was their cognitive abilities like similar to like hearing counterparts, or did they have like? Or I was wondering if you knew anything about like the cognitive abilities in them, if that like differed at all between like normal hearing counterparts.
Sorry, with the mask, I have troubles understanding the question.
Oh, sorry.
I think you're not alone in your office.
Sorry. I was basically just wondering if any like similar research had been done on like pre-lingually deaf adults, and if they're, I guess not, or if the cognitive decline associated with deafness, if anything similar was found in pre-lingually deaf adults, like, or if their cognitive abilities were like similar to their hearing counterparts.
Yeah, I read a lot of literature about cognitive decline, aging, and deafness, and it did not look at, but I did not see during my research, anything about prelingual deaf, about the same question in aging prelingual deaf. No, there's nothing. I think it's a too small population to really ask about that, and because prelingually implantees are starting to get aged, but not they're not that, I think it's a population that's going to appear, but they're too rare now because they have been implanted while they were congenitally deaf. I think they have started to be implanted in the 80s. So if they were 5 years old, they're not old enough to start cognitive decline. So that's, I think, why we don't have literature about that yet.
Okay, thank you.
It's a very good question. Yeah, maybe we will see something appear in this subpopulation.
Yeah, I guess it's a study you would have had to done like 30, 40 years ago before the implants became so popular. Thank you.
Thank you.
Do we have more questions? Anybody in the audience? This is your chance to ask Diane. Alexander.
Hey, thank you, Diane, for the talk. If we try to connect your findings with the clinical practice and having this MD PhD profile, makes you very, very relevant for this. Can we think of, stepping back a little bit, there's this idea in cochlear implant research of this holy grail of kind of personalized rehabilitation and predicting outcomes. And so with what you presented today, do we have some insights on potential interventions pre-implantation that could maximize the likelihood of positive outcomes, and or of post-implantation rehabilitation strategies that might be individualized to better optimize for outcomes?
Yes, the idea would be to select the patient who have developed adaptive plasticity, who needed to recruit the right hemisphere. So we can use a clinical test just by the pseudo-homophone rhyming test, or by what you suggest during our discussion during FNIRS, to see whether patients need to recruit the right hemisphere, and those we know that they have a prediction of poor cochlear implant outcome. So they will need a different rehabilitation than the ones who are good lip readers and who can rely on the audiovisual interaction. So the question is, well, my question is why some people are good lip readers, manage to rely on their audiovisual interaction. So can we really improve audiovisual interaction? Is it really plastic? That is a question I would like to answer. And in this case, do we need to, if audiovisual interaction is not plastic, maybe we should invent new strategies, because maintaining somebody in trying to learn lip reading, if audiovisual interaction is not plastic, then it is a waste of time. So we should develop new strategies. And that's the idea I was telling to Robert, is trying to cover the whole range of auditory memory. Would be maybe interesting, that not only language, not only audiovisual interaction through language, but all the aspects of auditory memory, so paralinguistic and other cues that are around us.
Thank you.
Thank you. So with that, I think our time is up. So I would like to invite all of you to thank our speaker one more time, either with your little icon or like an actual applause. Thank you very much, Diane. That was like a super engaging talk to kick off the 2022 here. There's also some appreciation in the chat coming in, I think. So with that, I'd love to, I wish I could say that, that we had like drinks on offer or something. There might be if you have some in your fridge, but you're gonna have to rely on that. With that, I wish you all a beautiful, beautiful afternoon, and looking forward to seeing you for our next talk. Thank you.
Thank you for your invitation and audience. Thank you very much.
Thank you.
Bye-bye.
Bye-bye, everyone.